afternoon, everyone. Again, this is Sean Kennedy. I am the Director of Health Information Exchange for the Mass HIway Institute, and I want to welcome you today to our monthly webinar on the statewide health information exchange, otherwise known as the Mass HIway. So for today, I thought we would walk through a number of items. First, I wanted to give you an overview of MIHI, the Mass HIway Institute, who we are, what we do. Then I'd like to go into we'll call it a 101 on health information exchange, just to establish a foundational knowledge for everyone before we move on. We can then do an overview of the Mass HIway. We'll give an intro to the last mile program and how that supports the Mass HIway, and then we'll talk about some use case examples and then open up to discussion. So let me start here. Pardon the quick technical difficulties. Okay, so from an introduction perspective, who is the Mass HIway Institute? And we are actually a sister or a child under the Mass Tech Collaborative. The Mass Tech Collaborative is a public-private partnership, quasi-state organization aimed at economic development broadly in the tech sector. And there's three organizations that sit under the Mass Tech Collaborative. One is the Innovation Institute. The Innovation Institute really catalyzes innovation in the tech sector. They've got things like the Tech Hub Collaborative, where they bring together government officials, academia, industry to collaborate around particular topic areas. The Big Data Consortium, and bringing folks together to think about the opportunity of big data and how we can exploit that here in Massachusetts. The Advanced Manufacturing Collaborative, the Innovation Index, which is published each year, and I think the most recent one was published about a month ago, establishing what does the innovation economy of Massachusetts look like. Then there's the Mass Broadband Institute, and they're focused on the adoption and the implementation of broadband technologies. So Mass Broadband 123 is the big program, and that program is actually coming to an end where they've laid down over 1,000 miles of fiber across western and central Massachusetts, really getting people access to broadband activity. Pardon one more moment while my computer is optimizing the resolution. And then we have the Mass HIway Institute. And for MIHI, we do a number of things. We're again, we're the state designated entity for health information technology, and we help coordinate health innovation technology and competitiveness across the state. We really work to accelerate the adoption of health IT. We've got a number of approaches that we use to do that. We promote health IT. We advance the dissemination of EHRs in all care settings. We want to get all providers connected to the statewide HIE in managing the ONC grants for HIE and the Regional Extension Center, which focuses on EHR adoption. So we work to become this go-to resource for folks around health information technology here in the Commonwealth. And there's a number of drivers out there that are pushing things forward, and not the least of which is Meaningful Use 2. So the Meaningful Use 1 program proving very successful, a fair amount of funding coming into the state and being distributed in support of that endeavor. And now we're moving to Meaningful Use Stage 2. And Stage 2 requires the use of an HIE, and that started here in the earliest period that you could start reporting is October 2013. Our high-tech funds, this is the federal funding that's being managed and distributed through Office of National Coordinator, is coming to an end the first week in February. So the REC program, the Last Mile program, some of our challenge grants, we're all transitioning off that funding onto other funding sources, and that's certainly a catalyst or a driver of change. And you may have heard about these legislative mandates. So one of the big ones is physician licensing requirement. This starts January 2015. What that means is, to be defined some of the specifics, but generally, Massachusetts requires physicians to be proficient in the use of health information technology as a condition of licensure. And proficiency at a minimum means complying with the meaningful use requirements. Now I'll say that that is being worked out, and work through with the Board of Registration in Medicine is to exactly the specifics of the criteria. But the general concept here, there has to be some demonstrated use, whether it's consistent with meaningful use or a bit different to be determined. All providers in 2017, January 2017, all providers in the Commonwealth, this is doctors, this is chiropractors, this is nurses, this is everyone in between. If you're a provider, provide care, you have to be using a fully interoperable electronic health record system that is connected to the statewide exchange. So some fairly significant mandates that are looming out there, and what we really want to do from a MIHI perspective is to prepare the community and the market to not incur any penalties that may come out of those particular mandates. And the way we do that is we work on this continuum. We call it kind of the motivate, adopt, impact. And along that, we break it out into these things like awareness, education. We feel that there's a lot of opportunity to grow awareness of health IT, educate people broadly on health IT as a way to then motivate some action and move the market forward. There is a big effort around engagement, and through engagement, we have the opportunity to get people to implement and thus adopt these EHR or HIE or in general health information technologies. And then once you adopt them, it's not good enough to just adopt. We want you to optimize. We want you to gain the impact in your organization, whether it's how HIT can impact your care setting, clinical outcomes, population health outcomes, cost containment objectives you may have, efforts around the triple aim. How can we have HIT support those efforts and really bring the value that you're seeking? So from a Motivate perspective, we work in a lot of communication efforts. So this webinar series is one example where we generate some demand, we educate the community in an effort to motivate some activity forward. We had a regional meeting series that was very successful. We just wrapped that up, I believe, last week out in Worcester. We had 5 events over the course of about 6 weeks. Springfield, Taunton, Worcester, Boston, and it was really a wonderful set of activities that we did where we educate the community around EHRs, HIE, we bring in a speaker to talk about their success stories, and then answer any questions. And it's a whole morning activity to include some workshops. We have a HIway newsletter where we distribute that broadly. We have the MIHI newsletter that goes out as well. And then there's this EU-US conference that's put on annually, the most recent of which was about 2-3 weeks ago. From an adoption perspective, we've got the Regional Extension Center, and the Regional Extension Center is all about helping, we'll call them primary care providers, adopt and implement EHRs, moving toward meaningful use, stage 1. And presumably in the future, we're really working that same audience to get them towards stage 2. Medicaid Incentive Payment Program, that's one of the other big programs that's under the MIHI set of programs. We work with Mass Health to administer that program on their behalf. And then the Last Mile program, where we administer a couple grants, the implementation grants and vendor grants. I'll get in a little more detail on those here shortly. From an impact perspective, we do have a charge to spur economic development across the Commonwealth. So this means engaging industry and getting them aware of what we offer here in the Commonwealth and really encouraging firms to do business here in Massachusetts. There's also a workforce planning component, and we're doing a fair amount of research around providers and consumers to really understand the need to help us better articulate and define some of the programs. So let's go into our health information exchange part of this. And let's start with a 101. And this is just some basic information you may know, you may not know. But let's start with what is HIE. Right, so we start out with what is HIE. It's really the electronic sharing of health information among varied healthcare systems. So this could be between 2 unaffiliated organizations, hospital A, hospital B. Heck, it could be within an organization, but you have disparate systems that are not interconnected. And being able to exchange information between 2 disparate systems while maintaining the meaning between them really gets to that concept of interoperability that HIE helps facilitate and move toward. There's 2 basic models that we look at. You may have heard of the concept of push versus pull. And in a push environment, the big difference comes in the consent application. So from a push perspective, you are sending information to a known entity. and you have the ability to capture consent on your end and to push that to someone else. In a query environment, it's very different, or a pull environment where you're querying the community and pulling information from them for your use. So in that sense, consent is complicated because the organization that you've requested information from has to know that you gained that consent, and they have to feel good that you did it in a manner consistent with their policies. So that creates a bit of procedural challenges in the pull environment. Content standards. So this is how we format and display sets of data. And you may have heard of this CCDA. This is the Consolidated Clinical Document Architecture from HL7. You may have heard of CCD, C32, CCR. These are things that meaningful use requires you to use as part of content display. And we frequently get asked what data is available through these different create and display capabilities. And what we say is it's varied, but what I can say is that the common meaningful use data set, which is a data set that groups together all the data elements that were required as part of meaningful use stage 1 and stage 2 and puts them into a big set of data. So when you go and look to exchange with another organization, this is likely to be the data that the EHR vendors and the particular organization has spent more time than not thinking about how to mobilize or make available. That's not to say that other data couldn't be available, but this is the data you're generally going to see. Transport standards. So now that you've defined your data, you've formatted your data, you've got this payload, the question then is, how do you send it? And there's certain standards around that. You may have heard of SMTP, SMIME, or XDR SOAP. These are two different types of protocols that could be used in a transport standards. Health information service provider. So this would be the organization that takes on the responsibility to manage this environment of secure exchange. So they may do things like certificate discovery and facilitate that service, message delivery, provisioning of direct addresses. These are things that a HISP or a health information service provider would manage. And the Mass State HIE or the Mass HIway is such an entity. It is a HISP. It is from the Executive Office of Health and Human Services that assume that role. So we added a couple slides around meaningful use, and they're fairly just one slide, straightforward, to describe the different elements of meaningful use stage 2 that have an exchange component. And you may have heard of this patient engagement. This is the big part of meaningful use stage 2. They introduced this patient engagement component, view, download, transmit. This is a big element that does require movement of information outside of your organization, which would imply an HIE component. Transitions of care, referrals, discharge summaries, public health reporting for immunization, cancer registries and such, e-prescribing, lab results reporting. All of these have a requirement to move data around. Whether or not you use the Mass HIway is a different story, but there is a requirement for health information exchange. And this next comment here, really what this boils down to is we've got two big entities at play here. You've got the Office of the National Coordinator that sets the standards for EHR certification. And then you've got CMS, the body that defines meaningful use criteria. And those are two separate things, but they are highly entwined. And as the example goes, you have to have a certified EHR to then be able to attest for aspects of meaningful use. So they work together. This comment is more around that CMS leads that effort on meaningful use and the criteria that's defined there, whereas O&C defines the certification requirements. And the two are tied very tight together. And then the EHR technology for meaningful use stage 2 must be certified to the 2014 edition EHR certification criteria. So it's a good question to ask to your EHR vendors. If you're looking to attest for meaningful use stage 2, is your EHR 2014 edition certified? And that's a good question to ask your vendor. So let's go into the Mass HIway and do a little overview on this one. First off, what is it? This is a collaboration between the Executive Office of Health and Human Services here in Massachusetts and the Mass eHealth Institute to deploy secure statewide information exchange. EOHHS, they lead the development of the infrastructure, of the HIE, and the operation of it. So the onboarding process, the provisioning of addresses, this is all done by EOHHS. MIHI leads the last mile program, and our job is to grow the adoption and connections of those to the statewide HIE. So we want to generate the awareness, education, and demand to get connected, and then facilitate that connection process. And we do it in a way that we want to do it as aiming toward demonstrating measurable improvements in care quality, population health, and healthcare costs. And I'll talk about how we're doing some of that here shortly. And then obviously we think there's a lot of opportunity around innovation that we want to catalyze. And these efforts are funded through a big grant from ONC, but then also using some CMS funding with state matches, and this will be sustained through private sector contributions. So we're guided by an HIT council. HIT council has 22 members. It is headed by Secretary Polanowitz, the Secretary of HHS, and there are 4 advisory groups that sit under it, the consumer group, provider technology, and legal and policy advisory groups. And these 4 groups advise the council and help us evolve the health information exchange, the Mass HIway. So we launched the exchange back in October of last year. So October 16th was the big day. What you see there is a picture to your left of the Ether Dome at Mass General Hospital. And at the podium at your top right is the governor with Dr. John Halamka, the CIO at BI. Dr. Halamka was the moderator for the Golden Spike event, and the governor was the patient who was getting his records sent from Mass General to, in the bottom right-hand corner, Bay State, you can see on the video screen, sending that along. And it was really a remarkable day and event. All those folks gathered around the video conferencing screen are the other Golden Spikers. We had 16 organizations who were participating in the Golden Spike ceremony. And it was really a wonderful event where we kicked off the exchange, made a number of transactions. There was a fair amount of activity with the Twitter sphere on this, and that launched the exchange. But since then, clearly many improvements have been made to the HIway to make it a really wonderfully value-added service. And so we say that Mass HIway is really this hub for information exchange. We're not a clinical repository by any means. We are facilitating transactions between organizations. And the organizations that can join the HIway, you can see listed here, acute, post-acute, acute and post-acute care organizations, long-term post-acute care, ambulatory care, public health labs, pharmacies, and payers or health plans are all eligible to join the HIway. We say if you're involved in TPO care coordination activities, you're eligible to join the HIway. And each use case will be considered independently, but generally that's the guiding rule. Now the patient is grayed out there, and it's not that we don't intend for them to join. At this point, though, we don't have the capability to have the patient join, but that's certainly in the plans for phase 2. Some of the benefits we've heard, read about in the literature, improving and streamlining care coordination, fewer medical errors and improved patient safety. So presumably by having information prior to rendering care may present some opportunities for reduction of medical errors. Reduced duplication, certainly knowing about a procedure or a test that was performed may influence that decision. It certainly supports achieving meaningful use. We think there's an opportunity to reduce costs throughout the healthcare delivery system. The interfaces that support public health reporting and analytics, if you have 5 different interfaces, perhaps you can just write one interface to the HIway. It could be an immediate cost savings. And we also think it's foundational to accountable care organizations and this value-based healthcare models. So one of the large areas we hear about when people come into this is that there's this transition from, if you will, in some organizations, faxing of paper records or the movement of paper records through my privacy office before they go out, right? So there is this human element, this very stable intervention point where you can control the release of this information. And when you introduce the HIway and automating some of this activity through an EHR, there becomes this question of trust and making sure that it's done in a manner that's consistent with what our organization deems appropriate. So we say there's a trust fabric here. And the Mass HIway, again, serves as that transmission medium. And when you send your information out over this secure platform, you want to feel confident that it's going to where it needs to go, and it's encrypted, And this implies a fair amount of security, encryption, authentication, these being some of the technical underpinnings of the highway. And then the privacy components where we talk about participant packets, patient consent. These are more of those legal documents where someone has to be accountable to the actions of their organization on the highway. And by signing these agreements, we collectively, who are part of the Mass HIway, all agree to operate by the similar rules of the road. And by bringing together the security, the technical underpinnings, and the policy privacy efforts, we achieve this trust fabric. So we're currently in phase 1 on the Mass HIway. We say this is the send and receive mode. So the state has assumed a HISP role, which is a directed exchange of electronic health information, where a provider can push information from one provider to another. And there's a number of use cases that we'll share a few of those with you here today. Phase 2 layers on a fair amount of value. This is where we get into the search and retrieve. So this is where you can query the community using some of the new tools. There's going to be a master person index established, relationship listing service, and a consent database. And there'll also be the building out of some Department of Public Health registries and a fair amount of patient-directed exchange that we are optimistic we'll get into late next year. But the basic idea around phase 2 is that you could query Sean Kennedy in the community, and that relationship listing service, assuming there is a match, will then present back to say that Sean has a relationship with Bay State Health, Bay State Medical Center, UMass Memorial Medical Center, Mass General Hospital. And then the doctor who's making those queries can look at that and say, all right, this is the information I'm looking for, and then they can pull that down. So that certainly enables a number of use cases that can be pretty interesting of value to organizations. Now, first you have to get connected, though, before you can access these phase 1 and phase 2 services. So on the left-hand side, we see the different types of organizations that may want to get connected. And on the right-hand side, we see the different services that the highway may offer. But to access those services, you have to get connected to the highway. And there's a couple different ways you can get connected. Starting actually at the bottom, the most straightforward, though not automated method, would be a web mailbox. So if you can imagine secure Google, it's very similar to that. We've got our own web portal with a web mail where you sign up for an account and you're provisioned a secure internet mail account. And you can then manually attach documents and send those to other providers that you want to look up and address. So very basic way, but maybe a good way to get started for organizations that their EHR is not nearly ready to connect to the highway, or they just don't have an EHR. And it's also a great way just to get started with information exchange. The other approaches are, the first one at the top, we've got this EHR approach. So the EHR itself can connect directly to the highway. But to do this, the EHR has to have this direct compliant gateway built into it. And not all vendors have that yet. Though if they get a certification under 2014, a complete certification, they should have that capability. If they don't, you could have your own local gateway on your network that allows your back-end systems to connect to the gateway to then connect to the highway. And I'd say the difference between this local connection and what we call the LAN box, both of them are gateways that sit on your network, is that the LAN box is a pre-configured gateway provided through Orion Health that we are part of our subscription fees, or you could choose to build your own gateway, which would be that local gateway, and there's certainly reference guides that would support that effort. So a couple different ways to get connected to access the services. Now, that was the Mass HIway. That is the secure exchange environment to support health information exchange here in Massachusetts. But now we've got to get people connected to it, and that's where the Last Mile program comes in. Well, we grow the adoption of the Mass HIway by all eligible participants, catalyze innovation, ultimately looking to demonstrate measurable improvements in care quality, population health, and healthcare costs. So we say the goals are, we want to connect participants to the highway, we want to enable integration with vendors to the highway, we want to grow the use of services and grow the utilization of the highway, and we want to demonstrate and impact healthcare. And those are really the big efforts that you'll see our programs aim toward. But to get there, we've got to get to this cloud of our environment, and our environment has a number of barriers, incentives, enablers, and penalties. One of the biggest barriers at this point is that there's not a lot of on-ramps to the highway. HR vendors don't have these deeply developed and integrated workflows that connect to the highway. They're developing them, and we're supporting them, and some of them in that development. There's challenges around interpreting the opt-in or consent policy that came out of Chapter, actually 305, and further stated in Chapter 224. But Massachusetts is an opt-in state, and interpreting that by organizations has been a challenge in some cases, and other folks have interpreted it just fine. The highway is evolving. We're adding services and maturing our efforts, and that certainly is something that can create a confusion, but this is year one, and that will certainly work itself out very short order. Many incentives, meaningful use being the largest. We've got a couple of grants that we'll talk about. Many enablers, though. There's many reasons to do HIE, and certainly ACOs are a great reason to do this. We have community-based care transition programs, patient-centered medical home, lots of mergers and acquisitions out there, so I'm sure you've seen organizations getting bought up and trying to pull these different disparate EHRs together. And there's a fair amount of funding out there, we think, for innovation and outcome-oriented research, and HIE could certainly support that effort. But there's also the looming penalties, and we talked about the non-participation for providers come 2017, and then specifically for physicians in 2015 of not demonstrating some effective or meaningful use of an EHR. But there is positive light, right? So we are working through this cloud, and there is light through the cloud, and we have a number of programs that we've put forth to address some of these issues. And the first is the implementation and support program, where we bring on, we've got a number of, we call them client relationship managers, that work with you and orient you to how to get connected to the highway, and then walk you through the process of getting connected to the highway. And we're working with a number of organizations to grow that, those connections and grow the adoption now. We have an online environment for a community, and it's the eHealth community where we encourage people to come online and collaborate and share ideas and exchange best practices. We have our interface grant program, and this is really targeted at our vendor organizations. We've got 13 vendors, which I'll share on a slide, that are working quickly to get connected to the highway, and we're supporting them in that effort. And then the implementation grant program, we awarded to 30 different organizations, 32 grants. 2 organizations got 2 grants, and it reflects about 80, just over 80 organizations working to connect to the highway. And the idea was that we need to identify a use case. You need to bring together a set of trading partners and jointly apply for a grant. And we issued out 30 of those grants. So we're really optimistic we're going to have some great success stories come here the spring timeframe. And then clearly our education and outreach efforts support everything that we do. These are some examples of our grantees. You can see our grantees across the state. The greens are the actual grantees. The blues are the collaborators. And you can see there's a number of different things that we're doing. So the folks up in North Adams are doing referrals from specialty care to home health. Our colleagues out in Bay State, in Springfield area, are doing some management among heart failure patients with their different organizations out there. UMass and CVS are working together in the Worcester area, supporting two-way exchange of patients that show up in minute clinics. Down in Milford, we've got discharge summaries coming from acute care to a skilled nursing facility and home health. And then in Boston, there's a number of different efforts going on, one of which is an interesting pre-hospital transport care coordination for the homeless. We're working with an ambulance service and the Boston Center for Healthcare for the Homeless. So really interesting programs. But this reflects about 80 organizations working to get connected to the highway, and we're learning from them a lot of their different workflow challenges, policy challenges, making this a priority in their organization. And by next year, we should have some good lessons learned, gaining lessons learned now. We'll publish some lessons learned next year, and ideally these become blueprints for others to potentially follow. Our interface grants, these are the 13 vendors that we're working with. We've got actually about 26 vendors that we're working with more broadly on the highway. These just happen to be the 13 that received grants from us. And you can see there the different vendors. And these slides will be available, so you can go ahead and take a peek at them after this presentation. So one of the questions we always get from folks is how much does it cost to join the HIway, and this is always toward the end of the deck. But it's not a lot of money to join the HIway, and that's all relative, I know. But for our Tier 1 organizations, these are your big academic medical centers or multi-entity HIEs or health plans, that's the amount you're looking at. And there's a couple different ways this works. So let me orient you to this slide. The one-time setup fee is just that one-time fee you pay to get connected for the first time. Land HIE, if you recall back to the connection method, if you choose to go with the pre-configured gateway or the land box, a Tier 1 is going to pay $27,500. Versus if you have your own gateway, a direct, whether you have your own or your EHR provides it for you, you're going to pay $15,000 for that connection. And if you want to use webmail, it's $240 per box. And clearly, we don't anticipate many of the large facilities using webmail. We'd rather they use a direct or a LAN connection. And then that goes all the way down to, roughly $60 for any of those connections for your 1 or 2 doc practices. And you can see everything in between there. So let me do a shift over to use cases before we dive into some questions here. So there's a number of different ways people are choosing to use the HIway. We're just going to share a couple with you here today. This first one is a PCP could be sending a referral over to a specialist. So clearly they have to generate that referral document, use the HIway, specialist receives it, and then wouldn't it be great to know that the patient actually went to the appointment, which would be an interesting closing the feedback loop use case. But then it's also good to get that consult note from the specialist to the PCP. So we think that's a pretty interesting. It may be a basic use case, but we encourage folks to start with the basic use cases and then build it out from there. So a hospital referral, so it could be a specialist or PCP using the HIway to send information to a hospital. So maybe you want to make a referral to a specialty in the hospital, or someone needs to be admitted into a hospital. And then it'd be great if the hospital sent the discharge summary back to the care team once complete. And then wouldn't it be great if you knew your patient showed up in the emergency room? So could there be a use case that would allow the hospital to notify the PCP that has happened? And that's certainly possible. And people are working on that as part of our grants. Similarly, it could be a discharge summary. So once someone is admitted and they're then discharged from the hospital, that could automatically send out this discharge summary. Some of our folks are working on discharge instructions that may go to a home health agency, which is a really interesting one as well. And then a basic referral between hospitals. So going from acute care hospital to perhaps a more higher acuity hospital to manage particular patients. So it could be a referral there, but then they're going to come back to the more community-based hospital for follow-on and continued care. This slide here shows the different ways that our grantees are using the HIway. So if you recall, I said we had 32 grants, and in those 32 grants, they're all unique use cases, but what we did was we brought all the use cases together and then categorize them. And these are the high-level categories of use cases. And what you'll see here is we've got the send and the receive use cases, because they really are, a send is different than a receive. Maybe to close the loop, but they're two different elements and they have many different implications. So on the left side, you see all the receive types of use cases, care summary, referral request, discharge summary, topping the list. And on the send side, similarly, you see summary of care, referral request, discharge summary, topping that list. So I think it's safe to say that many folks are starting with sending a care summary as their use case, sending or receiving a care summary, or both, or sending or receiving a referral request or discharge summary. And then there's some of the onesie or twosie ones that are being done as part of the grants, where you can see an exchange of lab results, exchange of image notification, CANS data submission to Department of Public Health, and so forth. So a number of different ones. We count roughly 20 high-level use cases that are going on. So our goal here is to be able to better define these use cases and potentially even blueprint these so that others can use them. And you may not use them in their precise state, but there may be a starting point for you to then build things within your organization. So that actually wraps up my portion of the presentation. I want to take about a half hour to give that overview. And at this point, I can go ahead and open it up for questions. And what I would ask is let's start by using the chat function to type in your question, and then we'll go ahead and Tess, who's our coordinator on the call, will help read those questions to me, and then I can go ahead and answer those for you.
Hi, Sean. Right now we don't have any questions, but I'll give everyone a couple of minutes to submit them as they will.
Okay. And I'll say this, that don't be shy to ask a question. You'd be surprised at the questions people think are really just overly basic, but in reality, they're remarkably impactful. So I suspect if you're thinking of a question, it is a real and legitimate question. So any questions are certainly appropriate.
We have a question from Roy who asked, can we get the slides emailed to us? And the slides will be made available on our website, and we will email you the link to those.
All right. Well, I may have done just a remarkable job of that presentation, and maybe there won't be any questions. So I guess, Tess, there's no questions that you see?
Two more just came in. So the first one is from Catherine, and she asked, if we, as a home health hospice software vendor, want to get involved, what are the first steps we should take?
Yeah, that's a great question. So what I would encourage people to do is reach out to us. So you've got our contact information here on the screen. You can go ahead and reach out to us and let us know that you're interested in connecting to the highway. As a vendor, there's certainly a pathway to do that. We work with our colleagues over at EOHHS and Highway Operations to work with you to make sure that you've got everything you need to get connected and go from there. The advice I'd give you is, does your product have a direct enabled interface built into it? And if you do, that will certainly move things along much more quickly. But that certainly would be required to get connected.
Okay, and our next question comes from Kellen. Did you say that there is a system in the works for automatic notification of care team providers, say when a patient is moving between levels of care?
No, that doesn't exist today, and it certainly wouldn't be a service that the highway would provide. The highway will provide the transaction capability for organizations to bring it to life. So trying to think of some of our grantees that are doing just that, and I'm forgetting offhand. I think it may be South Shore Hospital. But one of our grantees is building in the ability to, when someone's admitted to the hospital, that does send a notification out to the PCPs that are loaded into their EHR. And clearly that has to be at the patient consent, but that is it's something that's being worked on. But it wouldn't happen at the highway level. The highway would just facilitate the transactions. And then what we would do is, in the last mile, is we would take that best practice that's developed by a hospital and a couple practices and work to share that more broadly so people can take advantage of it.
Another question from Kellen. Also, what resistance or worry for patients in opting in have you found, if any?
We haven't gotten a lot of resistance from patients for the organizations that are working to do this now. You know, the BI is probably getting the most active in getting people consenting, and they've built it into their current process, and it's usually going very well for them. I don't know specifically a lot of the other ones. I will say that it's something that people are working through because this is pretty new to a lot of folks. but to date, we haven't gotten any feedback from patients. And that could be by the sheer volume of patients, because there's, at this point, we're working on the number of organizations to grow connected to the highway.
Next question comes from Jean. Who within an organization would be contacting the highway to join? The IT department, the providers, senior management?
Yeah, that's a great question. So I tell you what, let me answer it a slightly different way, and I'll say that who in your organization is going to be who's going to champion this effort, right? So I always say I like to have providers at the table, because typically many of these processes are clinically oriented. Some of them are more clinical operations, right? So it could be administrator staff. But I like having the clinicians involved, because they're ultimately the ones who are going to have to be using some of this workflow. So it's really helpful to have them involved. We've been contacted primarily by the IT staff, and that's a fine group to contact us to initiate activities. But I'll say that one of the first things that we like to get going on is a discussion around how you want to use the highway in developing a really basic use case, just a basic story of what it is you're trying to do. And at that point, we start to think about how we can loop in other providers or other business owners that may have a role or a stake in this effort. So I'd say the quick answer is typically your IT staff. I would go with a management level to start, and then the team will build around what your interest is.
I think that's it for questions for now. I don't know if you want to give everyone another couple of minutes.
Yeah, we'll give it a minute. All right. Well, I guess we'll go ahead and wrap it up. Thank you, everyone, for your time. Thank you for your interest and questions. And you've got their contact information, so please let us know how we can be of support to you. All right. Thanks much, and have a great day. Bye-bye.